So this was a really large chapter. What we have here is a table just to kind of review everything in one place so that it's a little bit more organized. But again, it's not so much about kind of memorizing a lot of the details. Sure, there's certain things that you have to understand, you have to just commit to memory, but overall, if you understand the processes that we talked about, you just have to know what is the problem, and then you can kind of make sense at the diagnostics and some of the associations too. So let's take a look at the first one. We talked about SCID, right? So SCID, remember the problem. What's the problem? That's the first thing, absent T cells. Okay, so if I have absent T cells, there's going to be certain markers I would see. For example, if I was testing this in flow cytometry, the big one would be CD3 positive, right? If I don't have CD3 positive, that's pretty much universal among T cells. I might also see very low CD4. I might see very low CD8 potentially, right? So those are other markers, but the big marker to know is CD3. And again, if I don't have T cells, I'm going to have an absent thymus, right? Or a very involuted thymus potentially in these younger patients that are going to be presenting with this. And the classic newborn screening that we talked about is testing for these T cell receptor excision circles. Okay, so classically in SCID, if you see low Tregs, you want to start to think that this potentially is the disease that they're hinting towards. And if we also have concomitant B cell dysfunction or absent B cells, we would also see drops in our serum immunoglobulins. Now, there are certain diseases in general that you really want to know the presentation for. It's going to kind of call your attention to it. In SCID, it's usually going to be at that 3 to 6 month mark, which is going to be pretty classic among a lot of these different diseases, where they'll start to show symptoms, and eventually they'll have failure to thrive, recurring opportunistic infections. Opportunistic infections, we talked about things like Candida, pneumocystis, CMV, would all be very classic in these patients. But again, this alone is not always going to get you to the answer of SCID. You're going to really have to understand the diagnostics and understand the problem. And then they might ask, what is the cause of this patient's problem? It could potentially be a interleukin-2 receptor, which we talked about, interleukin-2 being that growth receptor that's going to help immune cell growth, right? And that's going to be X-linked recessive, or adenosine deaminase deficiency, which would be more autosomal recessive. And then we also talked about RAG mutations, not as high yield. All right, and then we talked about Bruton A-gamma globulinemia. Again, this is going to be absent mature B cells. So if I don't have B cells in the bloodstream, right, I'm going to have very low levels of my B cell markers on flow cytometry, 19, 20, and 21. And because of that, I have low serum immunoglobulins. And the other key point here is that your T cells should be normal, right? The T cells should be normal. I shouldn't have low CD3 in Bruton's. Combined variable immunodeficiency, what's the difference between these two, right? The difference is here I have absent mature B cells. Here they're present, they're just dysfunctional B cells. Okay, so I have B cells in the blood, so I should have CD19, CD20, CD21 markers on flow cytometry, but the problem is they're dysfunctional. So I still will have a decrease in all of my immunoglobulins and a decrease in my plasma cells because I can't get these B cells to actually become activated to become plasma cells. And so the classic presentation here, this is one situation where you really want to know that the presentation is going to be in an older patient. Now, it doesn't have to be between 20 and 40 years old. It could be a 10-year-old and 8-year-old, but the point is these patients are going to have less severe disease because they have B cells. They just don't work quite right as opposed to not having any. And so these patients will just tend to present later because the disease is less severe than these patients in Bruton's and SCID, which will present a lot earlier, around that 3 to 6 month mark usually. Selective IgA deficiency, again, what's the problem? It's right there in the name. We don't have IgA. That's the selective, meaning it's just IgA, right? That's the only thing that's going to be low here. When we have low IgA, I want you to think about Giardia, mucosal infections, but the big thing, the highest yield thing to remember for this, and this is usually how it presents, is going to be an anaphylaxis to a blood transfusion. Okay, so a patient that just got a blood transfusion for whatever reason, all of a sudden immediately goes into anaphylaxis. That's a classic patient for this. Again, that's due to that anti-IgA IgE antibody that's causing that to happen. Also remember that these patients are going to have a false negative TTG IgA in the setting of celiac disease, which is often associated with selective IgA deficiency. And that's because they don't have IgA antibodies. So that test is going to appear negative. They could still have celiac disease. It's negative because they also have selective IgA deficiency, meaning they don't have any IgA antibody. Hyper-IgM syndrome, again, what's the problem? Impaired class switching. If I can't do class switching, right, which comes from that CD40 ligand binding, if I can't do this, then I'm not going to make any of the antibodies or the isotypes that come from class switching. I might still have IgM. I might be making more IgM because my body is trying to figure out what's going on, right? So it's just going to keep generating a response with IgM, but I'm not going to have any of the IgA, IgE, or IgG antibodies. because I can't class switch. In hyper IgE syndrome, the issue here is impaired neutrophil macrophage chemotaxis. So this is kind of like what we talked about with leukocyte adhesion deficiency. We're going to have lack of inflammation because the neutrophils are not getting the signal to come to a certain part of an infection or an area that should be having some level of acute inflammation. And because of that, we're not going to have a lot of inflammation, and we're also going to have some classic features here, coarse facies we talked about, eczema. And when we look at the labs, IgE is typically going to be elevated in hyper IgE syndrome. IgE elevation very concomitant with eosinophils being very high. Now, the other thing to remember here is the interferon gamma is often low. Now, don't confuse that with interleukin 12 receptor deficiency, which is typically going to present a little bit differently. Interleukin 12 receptor deficiency is going to present with disseminated tuberculosis in a very young patient usually, okay? And that's because of the reasons we already talked about. You're not going to get interferon gamma release if you don't have interleukin 12 receptors on your T cells, okay? Because they can't then stimulate and do that next step of activating the macrophages. And so we're kind of jumping around a little bit, but that's your interleukin 12 receptor deficiency. But I just want you to remember that when you're comparing these two. So when you see low interferon gamma, it could mean either one. You got to take, if they're giving you information about IgE and eosinophils and, lack of pus or abscess without inflammation, you might be thinking more hyper IgE syndrome. If they're telling you that this patient has recurring TB infections, for example, and they potentially are, not responding to a TB skin test, something like that, you might think more interleukin 12 receptor deficiency. All right, Wiskott-Eldridge syndrome, we'll talk about this one a little bit more in the hem-onc section, but again, you have to remember, what's the problem? The problem is impaired antigen presentation. That's because we have cytoskeletal defects that are going to kind of inhibit our cell signaling. Okay, and so if we have impaired antigen presentation, the classic things you'll see are some deviation in the immunoglobulins, but that's not what I'm really looking at. I might see that, okay, the IgM, the IgG is low, but that's kind of, in some ways non-specific when you're comparing these diseases. The thing that I'm really looking for with this disease is I'm looking for this patient to have thrombocytopenia and unusually small platelets. Now, you can see thrombocytopenia in diseases like IPEX syndrome, where you have some component of autoimmune disease, okay, where you start to kind of attack your platelets, and that's called immune thrombocytopenic purpura. We'll talk about that in the hem-onc section, but the thing that stands out here, though, in Wiskott-Eldridge syndrome is that the platelets are really, really small. And they're really small because we have cytoskeletal defects and impaired communication between cells. So it makes these very unusually small platelets. Okay, so that's what I'm looking for. Now, if you have low platelets and they have some kind of defect potentially, the thing that you're looking for here is going to be purpura, easy bleeding. These patients might have epistaxis, recurring nosebleeds, very classic, or bleeding for a really long time after a cut, requiring them to go to the emergency room or something like that. That would be very classic for this Wiskott-Eldridge syndrome. Now, the other things you can see with it, you can see recurring infections, you can see eczema. Again, these are more non-specific in the setting of these diseases that we're talking about, though. Chronic mucocutaneous candidiasis, again, we already talked about this one being a poor response to candidal antigens. That's the point. So you can get these recurring infections, recurring mucocutaneous candidal infections. Again, they shouldn't be in the blood, right? You shouldn't have a candidal endocarditis unless we're talking about a neutropenic patient. And we're going to diagnose this by having an absent cutaneous reaction to candidal antigens. And we have IPEX syndrome here. And IPEX syndrome, remember, this is going to be your regulatory T cells, FOXP3, low levels of regulatory T cells. And so we kind of hit on this a little bit. And I didn't want to add too much in. Remember, this is going to present in infancy very early. And the polyendocrinopathy is really the big thing I want you to remember. I'll put that in red here. So polyendocrinopathy, because, that's going to make this stand out. So we're talking about things like hypothyroidism, hyperthyroidism. It could be either one very early in life. It could be pancreatic disease. These patients could have type 1 diabetes. All very classic. They also can have enteropathy, skin lesions, which are more, non-specific, especially the skin lesions. But again, the thing that just zooms you in on IPEX syndrome is going to be the low FOXP3, CD4, CD25 cells on flow cytometry. They're talking about T cells. The other T cells are working just fine, though. You still have a T cell response. It's just that the regulatory T cells are not functioning the way that they should. So hopefully this simplifies things. Again, first thing you always remember is what's the problem? Are they giving you any diagnostics? And then are there any key pieces of information in the presentation? And I think I highlighted most of the key things in red and in pink here in terms of what you really want to know in the presentation that's going to kind of zoom you in to that disease process.